Hi, I'm Phil here.
Laura.
I'm a visiting professor of clinical microbiology from Norway and then multiplex, so I met Cass.
Yeah, the other day.
Yeah, the other day. She's quite strong. And you are?
Veterinarian.
Yeah. I have a good relationship with him. I've been working with him. Yeah.
Generally.
A wider species repertoire. Yeah. Okay.
Kaz should be
Yeah.
coming. He should be file.
I've been working in veterinary practice. Have this whole partial use. That's a follow-up study. This kind of quality.
Yes, that's what I work in. Veterinarian. Yes, so working in the veterinary faculty in Ierano. So we, and both of us are in the it's very loose. That needs to be prescribing behaviour choices are restricted. So tetracycline and tetracycline and tetracycline. So if you have only one choice, then it means you can't choose anything alternative to that. So
Good morning, everyone. Thanks for joining us. Our first presenter this morning is Leslie Dowson, and she will be talking about her work in aged care.
Thank you, everyone. Again, I'm Leslie, and this is some results that I have. I'm the PhD fellow for NCAS, working on AMS in aged care, and this is one of our projects about nurse-led respiratory multiplex PCR testing in aged care homes. This presentation was first presented in February at the Australian Society for Antimicrobial's annual scientific meeting in Brisbane. And I'd just like to acknowledge the help I received from Rhonda Stewart, Caroline Marshall, Kirsty Busing, Deborah Friedman, and David Kong in conducting this study. So a bit of background, probably not surprising, but respiratory tract infection in aged care homes are common, and antibiotic prescribing for them is also common and often unjustified. We have really good data now thanks to the Aged Care National Antimicrobial Prescribing Survey. The latest year that's fully published is 2016. And in that year, of the total antimicrobial prescriptions for symptomatic indications, respiratory tract infection was number one with 34.5% of all prescriptions that year. I guess importantly and unfortunately, less than 40% of those met the McGeer criteria. The McGeer criteria is an infection surveillance criteria used in long-term care facilities. And in AMS, it's often used as a criteria of convenience when looking at appropriateness of antibiotic prescribing. So in this case, the McGeer criteria was for pneumonia and lower respiratory tract infections, because generally for upper respiratory tract infections, antibiotics are not required. So we're looking at about 60% could be questioned as potentially inappropriate during that year's survey. In addition to upper respiratory tract infections, up to 36% of community-acquired lower RTIs in older people are viral. Viral pneumonia is uncommon in younger, healthy adults, but it increases in prevalence with older age and chronic disease, which of course in aged care homes you will find a lot of people of older age and with multiple comorbidities. Influenza, RSV, and human metapneumovirus are the most common viruses which cause serious lower RTIs in older people. Influenza last flu season in aged care came into the popular media on several occasions because of some deaths in aged care. Important to note that even with high vaccination rates, there's not full coverage in aged care homes. And so influenza vaccine effectiveness against GP presentation has ranged from 38 to 60% in recent years. And in the years that are covered in our study, it was 42% in 2016 and at 33% last year. And this is in the general community. In aged care homes, it's probably less than that because in older people and people who are unwell, the seroconversion of the vaccine can be suboptimal. In addition to that, deciphering what is actually the cause of an illness when you have an influenza-like illness is very difficult based on signs and symptoms alone. And the therapeutic guidelines actually recommend these rapid specific tests on nose or throat specimens for the assessment of community-acquired pneumonia in adults, pneumonia in residents of aged care homes, as well as influenza-like illness. So when I'm talking about rapid specific tests, we're talking about respiratory PCR. In addition to this, in 2016, this was a communication that came from the acting chief medical officer of Victoria, sent to all aged care providers, and they were asking for standing orders for multiplex respiratory PCR to be put into the aged care home ahead of influenza season. And they asked for standing orders importantly, and the reason why we actually trained up the nurses to do this is for a number of reasons. And many aged care homes, in fact, most of the ones that I've visited, don't actually have a medical professional that oversees all the infections in the home. So there's often an infection register, but that's the responsibility of the nursing staff to complete and to monitor. In aged care, people who enter aged care are allowed to keep their general practitioner from the community. It's considered a community setting. So what sometimes happens is that many aged care homes have multiple general practitioners who are caring for just a few residents within the home. If that one general practitioner has one resident sick, another general practitioner has another resident sick, a third one has another one, there isn't necessarily one medical practitioner who will put together that they actually have an outbreak because they're only looking for their particular residents. Whereas the nursing staff who are there all the time, who are responsible for the infection register, have a better global view of what's going on within the aged care home. Also, GPs may only visit once or twice a week on dedicated days, so that's another reason why we concentrate on getting the nurses to do the swabs. It's maybe convenient if you become unwell on the day your GP is visiting, but on the day your GP is not visiting, we still want someone there to check to see what's going on. And lastly, some work that we're doing in our group and some work that's already been done really shows that nursing workforce in aged care can be conductors of antibiotic use and antimicrobial stewardship in the aged care home. So you really ignore the nursing workforce at your peril when looking at AMS in aged care homes. So what we want to do is support the nurses to take a more proactive stance on this. So back to our objective. So our objective was to describe the influence of standing orders for nurse-led respiratory PCR testing in residents with new onset respiratory symptoms on the changes to antibiotic prescribing in the aged care home. So we wanted to see what the effect of that would be. We had 7 aged care homes affiliated with 2 tertiary health care services, a total of 318 beds. Health Service 1 has now completed their 12 months, and Health Service 2 we've completed 6 months, and we're currently undergoing a statistical review to see whether or not we ought to collect the next 6 months. As you can see, Home 4 and Home 5, we have 12 GPs and 7 GPs treating residents within those homes. In total, we had 29 GPs, and that doesn't also include the locum staff that fed into the home, as well as hospital in the home services and other prescribers who can potentially treat residents within the homes. So this was a pragmatic prospective observational cohort study observing what the prescribers did in response to these nurse-initiated respiratory PCR testing. The nurses at the aged care home received training in the recognition of the respiratory tract infections. That's per the McGeer criteria, as well as specimen collection. And that training was done by nurse educators, infection control personnel at the health services, and also we had some GPs feed in and help us with that as well. The standing orders were introduced. So a pre-filled pathology collection pad, as well as a basket of the flock swabs were put into the homes, so that when someone had a respiratory tract infection, it was right there. And the data regarding the test results, the prescribing, and the clinical review was collected from the medical records. Because this was a pragmatic trial, we weren't putting in any sort of new tests, and so we were going with what was done in usual practice at the health services. So at Health Service 1, there was a one-step process where everything up there on the slide was tested for except the coronavirus at the first go. At Health Service 2, there's a two-step process, so they look for influenza, RSV, and rhinovirus first, and depending on the results of those tests, they may or may not go on to look for other pathogens, which included the coronavirus as well. So in total, we had 120 residents who were identified with new onset respiratory symptoms. Nothing in there is particularly unique about residents of aged care homes. At quite a high level of people that had some sort of cognitive impairment. I guess I want to make the point is some of the pushback we got for this was that, you know, you can't do the test in people with cognitive impairment, but I think that we have thus far proven that it is feasible. So cognitive impairment was the #1 most common comorbidity, and so on and so forth. We had 5 residents decline the swab, which was only 4.2%. And of all the symptoms that were identified, less than 25% actually met that McGeer criteria for lower RTR and pneumonia. So the rest were common cold signs and symptoms or influenza-like illness. So in total, we had 115 swabs that were actually taken. Most were done through the nose into the nasopharynx. That Health Service 1 was, had completed their 12 months, so they've had tested most of the swabs. Average duration to result was 1.3 days, so you're looking at 1.5 days to get the result back on average. We had some results back in the same day, and we had as many as 5 days, which occurred over the weekend, and that happened rarely. Looking at all the courses of antibacterials prescribed, these are courses prescribed, not necessarily given or completed. I don't know that there's any big surprises there. Amoxicillin and clavulanic acid was #1, followed by amoxicillin, and so on and so forth. Looking at the antivirals prescribed, that's 40 courses of oseltamivir, and that includes, those 40 courses include some prophylactic courses as well, which were given. Evidence of clinical review after a PCR result. So our benchmark for whether or not the person was reviewed after a PCR result was actually quite low. So it was whether or not there were any comments within the medical record that the RTI was still being investigated after the result arrived. So even with that, there were a handful, I think with 9 residents in total, that the PCR test was taken, and then there was no evidence anywhere in the medical record thereafter that anybody looked at it. So I'll cut off at the end a little bit, I'm sorry about that. But in total, there was 31.1% of residents had some sort of alteration to their antimicrobial therapy after a PCR result and clinical review. So that's either stop, start, or change your antimicrobial. So that happened for just over 30% of the residents. So what we found was a viral pathogen was detected in approximately half of the residents with respiratory symptoms who were tested. Most common being rhinovirus, but if you do add together the influenza A and B, it actually ends up being the most common viral pathogen found, and so on and so forth down the list. So we're looking at just over half we found a virus. So looking at those, about 70% of residents who had no alteration to their antimicrobials after a PCR and a review. There were those that didn't receive anything empirically to begin with, and there was no change made at review, so that was 30 residents. And they were mostly with nothing detected in rhinovirus, but there was a couple there who we did detect influenza, but weren't given anything for that. And then those who were receiving empiric antibacterials and the antibacterials were continued, that occurred in 43 residents, and 26 out of those 43 residents had a positive viral PCR result, but those antibacterials were continued. And so from the AMS point of view, this is what we were really looking for, and whether or not people were taking off their antibacterials or not. So looking at what was started, so that number 106, those were the total residents where we had proof that they were reviewed in some fashion after the PCR result came in. So about nearly 25%, 24.5% reviewed were prescribed something new after the PCR result. 10 had at least one new antibacterial prescribed, and 16 had at least one new antiviral. And that was actually the biggest response that we had to the PCR test results, were for the individuals where flu was identified. 15.1% of the total number of residents who we had results from were given oseltamivir in response to a flu positive result, which is a good thing for an aged care home. So looking at what was discontinued, and I guess from an AMS point of view, this is what we were really interested in. My numbers don't quite add up there because there were some residents who, if you're looking at this, sorry, we had empirically at the time of the PCR test, we had 43 residents who were prescribed antibacterials, 13 that were prescribed antivirals, and 7 that were prescribed both antibacterials and antivirals. So we had those 7 residents who received both at the time of the test. So if you're looking at the numbers and they don't quite add up. But anyway, so we only had 10 residents that were taken off their antimicrobials at the time the result came in review. 7 were taken off their antibacterials, and 3 were taken off their antivirals. But when you look at the reasons documented behind that, you really see that there was essentially 4 that looks like they responded to both the clinical status of the resident and the test. 2 which were discontinued their antibacterials, and 2 that were discontinued their antivirals. The rest of them that were discontinued their antimicrobials were for other reasons, such as being transferred to hospital or put onto a palliative care plan. So I guess conclusions at this stage is that respiratory viruses in aged care homes are common, and in the response to the PCR test results, the most common change was that initiation of the antiviral in response to a positive flu positive result, and that antibacterial discontinuation was not common even when there was a virus positive result. There was a paper that was published earlier this year in Acute Care Hospital that came out of Canada, which suggested that there needs to be an extra step put in place. So in hospital, what they found was that sending the results to an AMS team was required in order to affect the antibacterial prescribing results when it came in an acute hospital. And whether or not an AMS team in every aged care home is probably unfeasible, but we're thinking that there needs to be another step, whether it's a clinical algorithm that somehow imports PCR technology or some sort of other additional support to help people be taken off the antibacterials when there's a virus positive swab. But also important to remember in aged care homes that the PCR results are likely useful for other purposes, such as initiation of infection control interventions. And just anecdotally, that was sort of the #1 call that we got from the nurses, was wanting to know where the results were so that people could be taken out of precautions. So certainly there were 75% of the people who had the swab done that were put in some kind of infection control precautions. So there are likely other useful purposes for it as well. So I have many people to thank, but especially the nurses, GPs, residents, and family members at the homes who participated in the study, as well as the infection prevention teams at the health service. And a big thank you for NCAS as well for supporting the research. Are there any questions?
Yeah. In those nursing homes, in response to that, do you think that having a clinical pathway to facilitate the next steps, which is called the GP,
Yeah, so I didn't add that. There was definitely, part of the protocol was the GP was to be notified whenever they took the swab and when the results came in. Tracking that through a medical records hard, especially when the medical records are only in paper form. So I know the results were there. I know they were reported to the home, or else I wouldn't have been able to get the results. But whether or not the GP then took the step to go through it, or whether or not the nursing staff phoned him or her, we can't get that from a medical record, but it was part of the protocol they were supposed to. But I think they need that extra step to say, if you get a viral positive result, if it's clinically appropriate, they can be taken off their antibacterials.
Are you going to do any qualitative follow-up?
We are doing a qualitative follow-up at 3 of the health services where we have approval to go back and have a chat with the GPs to find out. Anecdotally, there were some notes in the medical records which said things like, you know, this has been reported to me that this person doesn't have influenza, and that kind of thing. So whether or not they were confident in the chain of information coming back to the GP in that fashion, I'm not sure. So I'll definitely go back and have a chat with that particular GP who, you know, his notes were, this was reported to me, but I don't know if he believed it or not. I don't know.
Impacted on his autonomy.
Yeah, I'm not sure.
Leslie, I wondered, this is all over the last year. I was wondering whether the results would be less focused on influenza in a year where influenza wasn't so much.
It could very well be. Certainly there was a lot of influenza around last year. Initially, so this started in, I think it was July 2016. So we did cover the previous, at least part of the previous influenza season, and certainly those results were more skewed before rhinovirus came in a lot, and it was really last year that we ended up seeing all the influenza coming in. So we'll see. It could be skewed because of just the unfortunate. We have, it's not up here because we haven't published it yet, but we have done a before-after analysis. The changes in antibiotic days of therapy. And a part of that, we looked at the rate of respiratory tract infections. And between the 2016 group and the 2017, it actually wasn't statistically significant, the differences in the respiratory tract infection. So although it was, it seemed flu was around a lot more last year, when you do the statistical analysis, it actually wasn't a significant finding.
The use of augmentin stands out, doesn't it? The moxiclav.
Yes, yes.
Because that's a low-hanging fruit.
Yes, very much so. That is, it does stand out, and having done all the, you know, medication chart reviews, that does stand out, definitely. Absolutely, yeah.
Hi.
Hi.
I'm visiting a clinical microbiologist and you, so I was invited to this John Club, so thanks for an interesting presentation and the use of, let's say, modern diagnostics and
yes.
can give influence.
Yeah.
Very important.
Yes.
So I have a couple of questions. What was the timeline between sampling and result? And the other one was, I'm not aware of this McGeer criteria.
Yeah.
Do you use McGeer criteria as an indication for, let's say, initiating antibiotic? And could it be used also as a criteria for taking a sample at all?
Yeah, so it was, so the, between the sample taken and the reporting of the result, the average was 1.3 days. But it blew out to as many as 5 days on some occasion, but we also got some back within hours, especially when there were active outbreaks in the homes. We tended to get the results back quicker. And the McGeer criteria is a criteria that was developed in America for long-term care facilities. And it is an infection surveillance criteria. There is another criteria which looks at minimum criteria to initiation of antibiotics. McGeer criteria tends to be more widely used in AMS circles, as well as in infection surveillance and prevention in long-term care facilities. And that's actually what we used to go into and talk to the nurses to say, this is what influenza-like illness looks like. This is what pneumonia and respiratory tract infection looks like. And those criteria are fantastic for long-term care facilities where they don't necessarily have typical, they can have atypical presentations of infection, and they have been, they've been around in the literature for a long time, and they've been refined over the years as well. So it's something that we can't say that definitively, you know, appropriate, inappropriate antibiotics, but comparing the signs and symptoms to the McGeer criteria gives us an idea of possibly or potentially inappropriate antibiotics. And when you're looking at more than 60% not fitting that criteria, it does suggest that there is some inappropriate prescribing there, likely for upper respiratory tract infections.
I know that stopping was sort of uncommon and that it did happen.
Yeah.
And I would have thought that scaling that up nationally, it would actually have a significant impact, I would have thought. Do you think?
I think so. I think that there has to be, it always comes back to aged care and confidence in aged care to make those sort of decisions. And I think scaling that up nationally with some sort of algorithm or some sort of support where you say that definitively, if a virus is detected, if they don't have ongoing symptoms of lower respiratory tract infection, you can take them off their antibacterials. And scaling it up, if we can't even get a few in every home every flu season, then it could be worthwhile. Yeah.
Sorry, I'm just following up on that. So if they are wanting to continue their antibacterial because they think that there is a lower respiratory tract infection, does that then suggest that they should at least have a chest x-ray, or is this just not?
So in my parallel work in looking at end-of-life care, chest x-rays, and especially looking at the work around the mobile x-ray units, because you think mobile x-ray units are fantastic, generally in aged care they're seen for fractures. It's not all that common that the chest x-rays are actually done for the chest infection. Prescribers would just rather prescribe something empirically for a suspected chest infection than go through the rigmarole of having a chest x-ray. So again, maybe that's also the possibility of some low-hanging fruit to try to encourage the use of chest x-rays more often than for lower respiratory tract infection. But overwhelmingly, the GPs that I've spoken to say, we only use that for suspected fractures. We would just rather prescribe empirically for a suspected lower respiratory tract infection.
I might have missed it, but how many were bacterial infections and were treated appropriately?
Maybe I didn't have that up there. I may not have had that up there. I'd have to look that up for you.
There were some there.
There were some. There would definitely have been some, and absolutely there definitely were some. I just didn't pull it up. So that's part of the separate analysis that we've done, is looked at the days of therapy which met the McGeer criteria, which didn't meet the McGeer criteria. That's kind of going into the paper, which we've done the analysis, but it's not published yet. So, yeah.
Thanks, that was great. One piece of good news was that no one who was diagnosed with a virus who wasn't on antibiotics was started on antibiotics. Is that right? The GPs.
No, you're right. There wasn't. There was people who were continued, but there was nobody who came back virus positive and was then started on antibiotics. You're right. They're absolutely right.
Already, because you know that some of those people, they're still coughing, doctor, 2 days later they wouldn't put on antibiotics. Yeah. And doesn't that suggest that maybe it's like status quo bias that's making people continue the antibiotics just because, now that we've started them, we should complete the course, and this kind of like faulty reasoning? Yeah,
I think there's a lot of status quo bias and also you have to remember that if your GP is only coming in every 7 days, if they start you on something, it could be that they don't get the results until whatever, and then they think, I actually want to review you myself. And by the time we get back to it, like there's a lot of time factors as well. We're also seeing whether or not we can do a time analysis with this as well. We'll see. Thank you.
Thanks, Arjun.
Our next speaker is Courtney Ierano, and she will be talking about her work in surgical antimicrobial prophylaxis. She is also an NCAS PhD fellow.
Good morning, everyone. So as Arjun said, my name is Courtney. I'm a PhD fellow with NCAS, specifically looking into the tertiary stream. I'll be presenting a presentation about one of my PhD topics, which is exploring the implementability of the surgical prophylaxis guidelines. I'd like to acknowledge NCAS as I am a PhD fellow. My supervisors Karen, Trisha, Darshini and Caroline who helped with this project, and also acknowledge that part of this presentation was presented at the ASA meeting in Brisbane a month ago. So why surgical antimicrobial prophylaxis, which is SAP? It's a leading indication for antimicrobial use in Australia. We do have guidelines available and they are endorsed by our national AMS clinical care standard. However, we still have issues of inappropriate use and non-compliant prescribing. So guideline implementability suggests that guideline development and implementing those guidelines don't always match up, and that is potentially influenced by many facilitators and barriers. So we want to find out what they are. So the aim of this project was to evaluate the implementability of the national guidelines for surgical prophylaxis. So they are the therapeutic guidelines, the antibiotic surgical prophylaxis chapter, and by doing that with a validated instrument known as the Guideline Implementability Appraisal, known as GLIA. So how do we do that? Well, first of all, we needed a guideline. So as I mentioned, the therapeutic guidelines was our guideline, specifically the antibiotic book or online section, and then further to that, the surgical prophylaxis section. So this is a screenshot of what our appraisers got. So they knew that they were to click on the surgical prophylaxis link, and also what's circled there is the contributors section, endorsements and so forth. So they to look at that section as well, completing the appraisal. When you click on that surgical prophylaxis section, there's many subsections. We modified this appraisal to look at two overarching recommendations. So first of all, general principles, and then secondly, the surgical prophylaxis for specific surgical procedures, as there's 17 subsections there. And in the interest of time for our appraisers to go through every single one, we just didn't think that would be time effective, and given the very similar intrinsic characteristics of each recommendation, we opted to go with sort of lumping them all together. For the appraisal, we needed appraisers. We used purposive sampling, targeting 6 to 12 participants across a range of key stakeholders, including surgeons, anaesthetists, infectious diseases, infection control, and antimicrobial stewardship. The instrument itself, as I mentioned, is called GLIA. It appraises the intrinsic qualities of guidelines and consists of 30 questions over 2 sections. The first is the global considerations, which are applied to the guideline as a whole. And then the second is questions based upon what is called the 8 dimensions of implementability. So these dimensions had questions within them, and they were applied to the 2 separate recommendations I talked about. So the general section and then the surgical specific recommendations. So these 8 dimensions are executability, so what to do, decidability, under what conditions, validity, how that those recommendations are supported by the evidence and the strength of evidence, flexibility, so the permissive of alternatives for those guideline recommendations, effect on process of care, refers to the impact on the workflow, measurability, so markers or endpoints to track the effectiveness of the implementation of those recommendations. Novelty and innovation refers to how the users consider that recommendation to be conventional or unconventional to the current practice. And then computability is an optional dimension. We included it as we appraised the electronic therapeutic guidelines, not the paper-based version. And that refers to how they can be operationalised in an electronic information system. For each of those questions, there are 4 responses, and that is yes, the criteria is met, no, the appraiser is unsure, or it's not applicable. And then based on those 4 responses, when we analyse those results, the options could have been, if all our appraisers said yes, then that is considered a facilitator. Again, if everyone said no, a barrier. And then majority yes, a borderline facilitator, majority no, majority yes, borderline facilitator, majority no, borderline barrier. When they said no, unsure, or not applicable, there was a free text option, so the appraisers could then explain or justify why they thought that was the case. So looking at our results, we had 15 people recruited, we had 10 complete the appraisal, so a 66.7 response rate. And from that, there were 3 ID physicians, 3 anaesthetists, a surgeon, an infection control consultant, and 2 AMS pharmacists. So for each appraisal, there's 51 responses, so 510 responses in total, and overall, 66.1% of the responses were yes, in general support of guideline implementability. Looking at the global considerations, in terms of facilitators, the recommendations that were identifiable and concise supported guideline use and implementability. There was no 100% no responses, so nothing was determined as a barrier. So I'll then discuss borderline facilitators and barriers. So things like the population being defined concisely, author credibility and internal consistency of recommendations were seen as borderline facilitators, and borderline barriers were less clarity regarding definition of the audience and a lack of description or mention of implementation strategies. I've got here for question 3, guideline setting defined, there was mixed responses from our appraisers, so it was considered a borderline facilitator and barrier. And then similarly with clear sequencing of the recommendations, there were equal responses for yes and not applicable. So it could be considered a borderline facilitator, but because this is looking at the guideline generally as a whole, some thought that whether it was sequenced wasn't actually applicable to that question. So I've just got some interesting quotes relating to these borderline facilitators and barriers. So there were obviously not 100% consensus, so some appraisers just justified why they thought no. So what was interesting regarding author credibility, it was not that the authors weren't necessarily credible, but weren't truly reflective of all the surgical specialties in the guideline for guideline development. And again, in terms of implementation strategies, they were just acknowledged that they weren't mentioned at all. Looking at the GLIA dimensions for the specific recommendations, again, there wasn't 100% consensus for a no, so there was no barriers per se, but there were facilitators and borderline barriers. Measurability, so the ability to measure outcomes of guideline implementation was considered a facilitator. And similarly with novelty and innovation, there were some exceptions though. So appraisers 2 and 6 noted that whilst the guideline recommendations are consistent with most beliefs of users, they noted that some surgeons have different opinions. So appraiser 2 said some surgeons have different views on when antibiotics should be used and which ones should be used. And appraiser 6 said that that again, similarly, that their beliefs aren't consistent with therapeutic guidelines. Not all anaesthetists are aware of redosing, and certain surgeons love to apply topical antibiotics. And again, therapeutic guidelines don't recommend or advocate for topical applications. In terms of borderline facilitators, so executability, a lot of the comments focused around the less directive instructions, which then did allow for user autonomy, but then for further potential variations in prescribing. And examples were given by relating to dosing adjustments in obesity and what actually then constituted excessive blood loss to then require antibiotic redosing. Similarly with decidability, the use of less directive instructions then allows, the appraisers felt that users could then interpret the recommendations to justify their own personal preference. So what they felt was a significant risk of post-operative infection rather than what's evidence-based. And then another quote from Appraiser 6 highlighted that different users have different knowledge, and then because based on that level of knowledge has a different rationale for decidability and how they apply the guidelines. So just some interesting points. Looking at borderline barriers, a key dimension was validity, specifically that evidence quality wasn't explicitly stated. But a key point that whilst the references were present, but there's no grading of their quality, but Appraiser 6 also noted that this actually isn't a feature of the therapeutic guidelines, and if we were to have explicit evidence quality grading, that the guideline would then be very long and less practical. So it's a bit of a catch-22. We want that sort of, we want that evidence quality there, but in a way that doesn't detract from the actual guideline recommendations, because that can further impact upon guideline implementation. Another question relating to validity was that recommendations won't justify. And Appraiser 8 made a good point that it wasn't quite clear as to which reference referred to which recommendation. If you remember, I can go back to the screen later on, but the key reference section is at the bottom of all the recommendations. So if people did want to find that information, they'd have to actively go look for that. But in saying that, these are guidelines, it's not an essay or a paper about the evidence, so we do have to trust that appropriate expert review of the literature has been provided in these guidelines. Another borderline barrier was the flexibility of the recommendations, specifically for patient characteristics, and Appraiser 1 brought up the issue of concomitant antibiotics, so patients already coming in on antibiotics and before the surgery, and how that influences surgical prophylaxis decisions. Computability, again, was a borderline barrier, and the big one was a focus on a lack of electronic patient data. A lot of the quotes on the screen sort of highlight that this is purely like hospital and site dependent, and generally not the case, and also that information might exist within the hospital setting, but not at the point of care of surgical prophylaxis prescribing. So on the ward maybe, but not in the theatre setting. And also to make decisions regarding surgical prophylaxis, they do need to be aware of that patient data. So as Appraiser 6 has mentioned, patient's weight, BMI, renal function and allergies, but again, that it might not be there at the point of prescribing. So with any research, there are limitations. So with this project, we did modify the GLIA instrument and how it was conducted. So not always easy to compare to other literature that have used this GLIA tool. And because we did group all the specific surgical procedures together, it didn't allow for that differentiation. I mean, it did depending on how thorough that appraiser wanted to be, but it didn't prompt for our appraisers to say what they liked specifically about the cardiac guideline as opposed to the orthopedic surgery. The GLIA tool also, the developers, they advocate that you should try and get overall consensus. So that would then have required that after all appraisers completed the tool, we got them all together or called them to then reach overall consensus. Given the nature of this project is more of a smaller exploratory study, we didn't really feel that that was necessary. So we opted not to do that. and as well a small sample size of 10. All the appraisers were Victorian and so not truly representative of an Australian opinion on the guideline implementability. And also, as I mentioned, the GLIA tool looks at intrinsic factors of guideline quality, implementability. So guideline usage and guideline implementability is purely not just based on the guideline itself, it's based on the appraiser, their behaviour, the environment around them as well. So while it gives some insight into guideline implementability, there's obviously a lot of other factors that come into play. So in conclusion, this was a first implementability study of Australian surgical prophylaxis guidelines. And overall, the guidelines were found to be intrinsically implementable, but borderline facilitators and barriers do exist. And based on what we found, some things that can help support our facilitators, all these facilitators and borderline facilitators, include ongoing audits such as the SNAPS, the Surgical National Antibiotic Prescribing Survey, as this supports that measurability of guideline adherence, uptake and outcomes. For developers to consider patient and practice characteristics to help support that flexibility of guideline recommendations. So maybe some further information or evidence on obesity and the use of concomitant antimicrobials. And then in terms of addressing the borderline barriers, we found some simple recommendations include increasing the engagement of the surgical craft groups in the guideline development and increasing the transparency or linkage of evidence. And that could potentially be adopting evidence-based grading, further guideline appraisals. So there's other tools that can be used to appraise the guidelines, not just in terms of implementability, and even appraising, using the same tool again in before and after the next updated version of the therapeutic guidelines antibiotic to see what needs to be done before they roll out the new version, and then reviewing at a point afterwards to see what worked and what didn't work. And then looking at computability, trying to propose ways to increase access to electronic patient information and decision support. And as well, those implementation resources and tools or strategies to support guideline use that weren't included at all as per our appraisers. As I mentioned, this project was a smaller exploratory project that is leading into larger qualitative research, which I'm currently undertaking. And this is looking at exploring both intrinsic and extrinsic factors that influence surgical prophylaxis prescribing. So this project has sort of informed what things we want to look at, and more so in the next project. Thank you. Any questions?
I had a question.
Yeah.
Because this is reviewing the therapeutic guidelines and they're currently undertaking evaluation, will this be fed back to them? I missed it.
Oh, yes. So this information will be fed back to the therapeutic guidelines for their update. Yeah.
They've seen a draft version of the manuscript.
Yeah.
And they're involved in the discussions. And the CEO, Sue Phillips, came from the UK, where she's very, in fact, I think she might have suggested the GLIA methodology, because there are a few guideline implementability methodology, but the GLIA is the most widely used, but I don't know how often it's actually done. So
there's a lot of literature highlighting that there's a lot of guidelines being developed, and a lot don't factor in this implementation process. So there is that push, and implementation and implementability is sort of a growing space. So there's a lot that can be done, and not just for surgical prophylaxis guidelines, but in general.
So I'm sure, maybe a technical question so people can hear it, but there are going to be a lot of people out there building guidelines for AMS, all sorts of guidelines, veterinary guidelines. Could you foresee a checklist for guideline developers that takes into account the core elements of implementability?
So Kaz's question was, do I foresee the use of a checklist to support or drive a guideline implementability process? And yes, I do. There's many resources available. It's just trying to identify what is necessary for guideline implementability. There's a lot of literature out there. There is actually, it's called the Guideline Implementation Network, GIN, and they have lots of resources available as well. You have to be a member to access, but I think it's a free membership. So I think it's definitely something worth looking into if you are in the process of developing guidelines and want to see what's the best way of developing them, but then actually implementing them into your workplace.
There's always a trade-off between people wanting guidelines which are full evidence-based with grading versus something which is usable at point of care. What are your comments about?
Well, yeah, like you said, it's trying to find that balance. There's no point in having an essay justifying one recommendation, because then based on some feedback from the qualitative project that I'm also doing is people that want to use surgical prophylaxis guidelines, they just want to know quickly what they have to use and why. It needs to be brief, concise, and I mean, I guess having the resource as a paper-based guideline or a longer document later on to review back to, if they want to review that evidence. But at the point of care, it does need to be brief and concise, and I don't think at the point of care they're particularly interested in the evidence grading. But in terms of I think what I'm trying to say is there should be the guideline, but then there should be resources. So there's the guideline, but then to implement that guideline, there should be like a checklist or a summary of that guideline on a laminated card that goes into the surgical procedure room, so that the surgeons have it then and there to use. But then if they do have questions about why it is what it is, there is the actual guideline with the references to go back to, because they're not going to be checking the references in the operating room.
There is a good precedent with the expert mycosis group, where we developed the National Consensus Guidelines for fungal use in PJP, which was an expert multiple consensus guideline with grading. And then the TG, prior to the publication of their last book, took the recommendations to ensure that they were reflected back of our consensus guideline, so that there is this expert consensus opinion, but it's reflected in therapeutic guidelines. So I think in areas where there might be a lot of studies and there's be some reasonable quality resource to go to, I think that's important. And I think that's how the NICE guidelines work, although I'm not sure if they have simplified.
No,
because they're like.
But usually the individual trusts have their individual documents that reflect what the NICE guidelines have recommended.
Yeah.
But they're lengthy documents themselves. So it'd be nice to have therapeutic guidelines as your
go-to reference. Yeah.
For the actual evidence as well. But I'm not sure if they're really heading down that line. Then have an overlay of resource to then apply to your local setting.
Yeah.
Because some hospitals won't have all of that. For example, for surgical prophylaxis, they won't have ENT or whatever specialty surgery. They'll just have
the relevant information to the site as well, and that's also like.
It needs to be easy to do that.
Yeah, and it's not just guideline implementability, but it has to be adaptable to be implementable to multiple sites. And in Australia, we have public, private, metropolitan, rural services. So it's trying to, how do you get one thing to fit many different services? So, and again, varying levels of technology and computability, with many hospitals moving to electronic systems and others that haven't got there just yet. So we're in a bit of a awkward sort of time frame where everyone's doing many things differently. So, yeah. Sorry, Robin, did you have a question?
Just a comment was that given that the TG is predominantly accessed online these days, there really isn't any reason why they couldn't have an additional information button, next to all of their recommendations that you can click on, which wouldn't impact on the usability of the guideline.
It's just clicking that button.
But if you want further information, it's there, and that could have both the references and also where things are based on expert opinion, a summary of discussion and what, how they came to that recommendation. It So I think sometimes it'd be helpful where there is perhaps two strong papers, but with slightly different recommendations, and they've maybe gone from one over the other. What was it about that paper that the panel felt, was more important or more pressing or something like that steered them towards that recommendation? So I think having a bit more transparency around that would actually improve, like for the sites that aren't really on board with the TG and what it's doing and don't understand the degree of input that people have into the guidelines, that it's a very big process to review all those guidelines and
Yes.
many experts involved. I think it would actually improve the reputation of the guideline and the fact that people would have more faith in it if they could see a little bit more about the processes that went on behind the scenes.
Yeah, so, and I had mentioned transparency as well. So it might not be necessarily that they need to grade each recommendation, but it's that transparency and linking those references. Because at the moment, I'll go back to here. So after all those surgical procedures, then there's the key references, and they're broken down into surgical prophylaxis for abdominal surgery, and then a list of references, but it doesn't say which one relates to which. And you really have to, if you really want to know, you have to spend a bit of time to look into that. So it's not as easy. It's great that they're there, but in terms of getting users on board, and it's not the easiest process. And then another issue as well is the evidence for surgical prophylaxis is older. As well, a lot of that evidence takes into account, with older procedures, so it doesn't take into advance and changes in practice over time as well. So, there is a need for the expert consensus because they need to sort of tie it all in together, but that transparency and linking it all back into the actual recommendations. Yeah.
I have a couple of questions because in my ignorance of the Australian system, do you have a national surveillance system for surgical site infections? And my second question is, you mentioned this audit system, SNAPS.
Yep, SNAPS.
Yeah. Australian actually. Do you elaborate more on that? Does the national system, does it make any difference in reports?
Yep. So SNAPS is a newer antimicrobial prescribing survey. So it was rolled out in 2016. So we've only got 2 years worth of data there. It's not mandatory. So I mean, it has its benefits, but also limitations because it depends on what our auditors want to audit. So if they specifically want to audit their orthopaedic unit, then obviously we're going to have more data on surgical prophylaxis for orthopaedic surgery as opposed to any surgery. It is a prevalent survey and longitudinal. So our appraisers have the option to then capture data over a 30-day period, so capturing that data regarding surgical site infections or other consequences from antimicrobial use. But again, at this stage, it isn't mandatory, so we don't have that depth of data, but it's a great place to start. And not only is it just capturing antimicrobial use, but also appropriateness, so in relation to guidelines. And not just the therapeutic guidelines, if there's local guidelines, it's directed therapy and whatnot. Kaz, would you like to add to that?
It covers the whole surgical admission, so it captures the length of stay, readmission, CD, surgical site infection complication, but more importantly, it drills into the perioperative management, so that includes timing, dose, repeat dosing, as well as a post-operative. So we know that there's 40% inappropriateness perioperatively, but there's also 40% inappropriateness post-operatively, and there are very important signals in the data that we have. So we've got, I think it was 7,000 procedures in the one last year. Just very important signals, in particular surgical craft groups where there's extended prescribing post-surgery, neurosurgeons, plastic surgeons. Nothing's a surprise, but the thing is, in order to generate change, we need the data. So it's the first time there's been meaningful data. So, and because NCAS is a health services research centre, it's about how to use data to affect policy and practice. So after the pilot results, the Australian Commission on Quality and Safety, which is the body that oversees hospital quality, have now included the recommendation for accreditation is that sites have to actually unaccreditate surgical prophylaxis audit. And at the moment, the SNAPS is the only one. You asked about surgical site surveillance. I think the only state that does it in a very, very comprehensive way is Witness, which have you met the Witness team here? They have a very, very comprehensive modules for a number of surgeries. They are targeted, so there's Caesars, colorectal surgery, orthopaedic surgery, and cardiothoracic surgery. And that is done across the state. It's mandated by the government, and there's benchmarking and direct feedback via CEOs if there are spikes in rates and actions taken. So that is best of breed, I think.
Michael.
Yes,
Yeah,
yeah. But it's not, I don't think the same thing is done everywhere else.
All right. Thanks, everyone.